very important topic known as TIPS. What is the full form of TIPS? It is transjugular intrahepatic portosystemic shunt. Transjugular intrahepatic portosystemic shunt. First question, it is a non-selective shunt in which stent is inserted between right hepatic vein and right branch of portal vein. For cannulation, right internal jugular vein is preferred. For cannulation of portal vein, Roche needle is used. For cannulation of portal vein, name of stent is Viator. Okay, now see how we are going to perform these tips. It's very easy and simple. Now have a look of this simple diagram. Can you see this is right internal jugular vein. It is going to drain into a major vein known as superior vena cava. What is this? This is heart. And this is what? Inferior vena cava. Now can you see this is liver. These are the hepatic veins. This is right hepatic, this is middle hepatic, and this is left hepatic. Now can you see this one is portal vein. I'm using green color. There is no communication between portal vein and hepatic vein. No direct communication. I'm going to create one direct communication with the help of this stent. Now can you see this stent is inserted between right branch of portal vein and right hepatic vein. What will happen after this? Can you see? In this case, the blood starts going where? From the stent into IVC directly. And if this blood starts going directly into IVC, what will happen? The portal pressure comes down. And whatever the complications are there, because of increased portal pressure, those are going to subside. This is the simple advantage of TIPS. But what's the disadvantage? You must be knowing that portal venous blood is deoxygenated. It contains toxins, nutrients. So what happens? There is high level of ammonia in portal venous blood. You must be knowing that urea synthesis occurs in liver. From ammonia, conversion into urea. Since liver is bypassed, high concentration of ammonia reaches systemic circulation. So what's the most common complication of TIPS? Obviously, encephalopathy. Second problem, since because of this Viator stent, there is increased venous return to the heart. If there is already overloaded right heart, that will be absolute contraindication. Example, right-sided heart failure, pulmonary hypertension, hepatopulmonary syndrome. These are absolute contraindications. So we are going to discuss what? Complications. The complications of TIPS. Most common complication is encephalopathy. And what is that substance which is mainly responsible for encephalopathy? That's ammonia. Second, there is stent stenosis, and there is stent thrombosis. So these are common complications. Encephalopathy, stent stenosis, stent thrombosis. I told you there is increased venous return to the heart. So any situation in which there is overloaded right heart, it's an absolute contraindication. So have a look of contraindications of tips, absolute and relative. What are the absolute contraindications? First, right-sided heart failure. Second, pulmonary hypertension. Third, hepatopulmonary syndrome. And fourth, polycystic liver disease. Why polycystic liver disease? Because anatomy is distorted, leading to increased risk of injury. Relative contraindications. First, portal vein thrombosis. Second, hypervascular liver tumor. And third, encephalopathy. These are the contraindications of TIPS. After that, indications are asked. What are the indications of TIPS? Indications of TIPS. The most common indication is prevention of acute variceal bleeding. This is most common indication. Second, refractory variceal bleeding. Third, refractory ascites. Fourth, refractory hepatic hydrothorax. Refractory hepatic hydrothorax. Fifth, hepatorenal syndrome. Sixth, Budd-Chiari syndrome. Seventh, veno-occlusive disease. And eighth, portal hypertensive gastropathy. Portal hypertensive gastropathy. These are indications of TIPS. Now see where we do the mistake in indications and contraindications. When the indications of TIPS are asked, at the place of hepatorenal syndrome, examiner place hepatopulmonary syndrome. Similarly, in contraindications, at the place of hepatopulmonary syndrome, examiner places hepatorenal syndrome. So you have to be very careful. Hepatopulmonary syndrome is an absolute contraindication, and can you see hepatorenal syndrome is an indication of TIPS. So now we are going to start shunt. Now have a look. What are the types of shunt? It is of three types. First, non-selective. second is selective, and third is partial. So non-selective, selective and partial. One by one we are going to discuss. First of all, non-selective shunts. Types of non-selective shunts. First is ek fistula. Second is side-to-side portocaval shunt. This is also known as SSPCS. So, side-to-side portocaval shunt. Third, interposition graft. What are the interposition grafts which are used? Portocaval, mesocaval, and mesorenal. After that, fourth is proximal splenorenal shunt. Proximal splenorenal shunt. It is also known as Linton's shunt. In short, it is known as PSRS. So these are the types of non-selective shunts. After that, selective shunts. So have a look of selective shunts. First is DSRS, also known as Warren shunt. So what is the full form of DSRS? DSRS means distal splenorenal shunt. And second is Inokuchi shunt. And third type is partial. So what are the types of partial shunt? Partial shunt. Any shunt, non-selective shunt with diameter less than 10 mm. Any non-selective shunt with diameter less than 10 mm is partial shunt. Now what is the concept of selective, non-selective and partial? See, if there is complete migration of portal blood flow, that is non-selective shunt. And if there is partial migration of portal blood flow, that is portal blood, that is partial shunt. I'm repeating. If there is complete migration of portal blood, that is non-selective. Partial migration of portal blood, that is partial shunt. And if one selected region is being drained, not the whole portal system, that is known as selective shunt. So see the examples one by one. First, ek fistula. Ek fistula. Now see what is done in this ek fistula. Have a look. This is liver. This one is inferior vena cava. This is portal vein. Now what I'm going to do, can you see? I'm going to divide this portal vein. Where? Here. Divide this portal vein. After that what I'm going to do, can you see? I'm going to ligate this. After ligating this, what I'm going to do, can you see? I'm going to suture it or anastomose it to the IVC. How? Like this. So this is the final diagram. So what kind of anastomosis is this? You can make out that this is what? End to side portocaval shunt. So this one is end to side portocaval shunt. Why? Because end of portal vein is sutured to side of vena cava. What is the biggest problem? In this, there is no blood flow to the liver, no blood flow from portal vein to the liver. Because of this, there is increased risk of hepatic ischemia, and because of increased risk of hepatic ischemia and complication, it's of historical importance only. Historical importance. So this is an obsolete shunt. It is not performed nowadays. It's obsolete. So this is ic fistula. What's the other name of ic fistula? Can you see? End to side portocaval shunt. Second is side to side portocaval shunt. So have a look. What is side to side portocaval shunt? In short, it is known as SSPCS. So can you see? In short, it is known as SSPCS. Now have a look of the diagram. This is liver. In this is inferior vena cava. And in this case, this is portal vein. What we are going to do? We are going to make the side-to-side anastomosis. Now can you see how? Something like this. So see, this kind of anastomosis is made. So side-to-side portocaval shunt. Now you can easily make out what this blood is going into IVC. This blood is also going into IVC, and this blood is also going into IVC. You must be thinking that from top, from where the blood is coming, can you see? This is the blood from left gastric vein. So even this blood is also going. This side-to-side portocaval shunt is the most commonly performed shunt. This is most commonly performed shunt, and it is the shunt of choice for refractory ascites, for Budd-Chiari syndrome, and for veno-occlusive disease. This is shunt of choice for refractory ascites, Budd-Chiari syndrome, and veno-occlusive disease. So this is side-to-side portocaval shunt. Third is interposition graft. Now have a look how we are using this interposition graft. Very simple. See this? This is liver. This is inferior vena cava. And this is one tributary known as left renal vein. Now you can see portal vein. This is portal vein. What is this? This is spleen. If we are using the interposition graft, can you see? Suppose this is the interposition graft. This is interposition graft. And this is also one interposition graft. Clear? So see what are the names of these interposition graft. Can you see? Interposition graft between portal vein and vena cava. So the name is portocaval. So first is portocaval. This one is between superior mesenteric vein and vena cava. So second is mesocaval. And this third one is between superior mesenteric vein and renal vein. So this one is what? Mesorenal. So first is portocaval. Second is mesocaval. And third is mesorenal. These are interposition grafts which are used. After that, there is PSRS, proximal splenorenal shunt. Before that, can you see again in this how the blood is going to flow? Like this, like this, like this, like this. So blood is going to flow. Some of you might be thinking that only portal blood is going into IVC or IVC blood will also come in portal vein. It's very simple. Always there is blood flow from high pressure to low pressure. Obviously, what is the pressure in systemic vein or IVC? It is 1 to 2 mmHg. How much is the normal portal pressure? It is 5 to 10 mmHg. So there is only one direction of blood flow from portal vein to IVC, not the vice versa. So next is PSRS or proximal splenorenal shunt. Now have a look of this simple diagram. Again similar diagram. This is liver. This is IVC. And this is the tributary on left side, left renal vein. You can see what this is portal vein. And what is this? This is spleen. Which part is proximal and which part is distal? In splenic vein, can you see? This is proximal and this is distal. In proximal splenorenal shunt, we are going to divide this proximal part. After dividing this proximal part, we are going to suture it to the renal vein. So what will be the final diagram? You can see the final diagram is something like this. The final diagram will be something like this. Can you see? The proximal part of splenic vein is sutured to renal vein. You want to see the blood flow? Have a look how this blood is going to flow. It's like this and like this. So blood is going to flow in IVC via renal vein. That's why it is known as proximal splenorenal shunt. And you know it is performed after performing splenectomy. So first we perform splenectomy and then we are going to suture the proximal part of splenic vein to the renal vein. In all these types of non-selective shunt, you can see that there is complete migration of portal blood. Now have a look of selective shunt. First is distal splenorenal shunt. The other name of distal splenorenal shunt is Warren shunt. And it is a type of selective shunt. Have a look of this simple diagram. Again similar diagram. Liver. This is inferior vena cava. This is renal vein. Now this is portal vein. And this is what spleen. I am going to divide the distal part of splenic vein. After dividing this distal part, can you see this part is divided? After dividing this distal part, what I am going to do, can you see? I am going to suture this part of splenic vein to the renal vein. In this case, you can make out that only this splenic blood is going where? Into inferior vena cava. Can you see this superior mesenteric one? Superior mesenteric vein, blood is still going to the liver. So it's not the whole portal system which is being decongested. It's only the left part of portal system which is being decongested, and that's spleen. That's why it is a type of selective shunt. What is the second type of selective shunt? That is Inokuchi. Inokuchi shunt. There is a mnemonic by which you can remember Inokuchi shunt, that is IVC. I means interposition graft. Interposition graft between V means vena cava and C means coronary vein. So it is interposition graft between vena cava and coronary vein. Clear? Now see how we are going to make this. Very simple. This is liver. This is inferior vena cava. This one is portal vein. And you must be knowing there is one tributary of portal vein on left side known as left gastric vein. What is the other name of left gastric vein? It's also known as coronary vein. And you know that there is portosystemic anastomotic site at G junction. So this is G junction. What we are going to do, we are going to attach one graft from the left gastric vein to IVC. So there is one interposition graft between this left gastric vein and IVC. And can you see what is the flow of blood? This is the blood flow. In this case, you can see only this G junction is decongested, not the whole portal system. And that's why this is Inokuchi shunt, also a type of selective shunt. And I told you, any non-selective shunt in which the diameter is decreased and it is made less than 10 mm, there is only partial migration of blood, portal blood, known as partial shunt. So these are shunts nowadays frequently asked in exam. Similarly, there is one type of shunt which is frequently asked known as peritoneovenous shunt. Now just break it. Break it. So what is peritoneovenous shunt? It is between peritoneal cavity and one vein. What are the names of shunt which are used? First, Levine. Second, Denver. And third, Minnesota. Levine, Denver and Minnesota. So how these shunts are used? These shunts are used for refractory ascites. Clear? Now just imagine if a patient is having refractory ascites. So can you see? This is the peritoneal cavity. And this patient is having refractory ascites. Now can you see? This is the vein. Which one? Right internal jugular vein. And this is superior vena cava. I'm going to use one shunt or graft between these two. Can you see? So this is the graft which is used between this vein and peritoneal cavity. Now what will happen? The ascitic fluid will start going into vein. The blood should not come into ascitic fluid. That's why what happens? In these interposition grafts, what is there? There is a valve. And because of this valve, there is only unidirectional movement. Question is asked, in peritoneovenous shunt, what is the preferred vein for attaching the interposition graft? Preferred vein is right internal jugular vein, followed by superior vena cava. So these are peritoneovenous shunt which are used for refractory ascites. So these questions are frequently asked